So good morning. Thanks so much for the invitation. I managed to get out of bed despite the fact that Montreal lost yesterday in overtime. I still managed to get here. So these are my disclosures. So I'm going to talk to you about mitral regurgitation and MitraClip, and I'm sure this is something that you're all aware of, which is the prevalence of mitral regurgitation, and I think you've seen this slide a million times. What I like about this slide is it shows all valve disease, and especially in mitral and aortic in particular, in this population of patients or people living in New York State. And what you see here is that the prevalence of moderate or severe MR was about 6.4% in patients aged 65 to 74, but it jumps to almost 10% in patients over the age of 75. And this is a paper from Australia where they looked at patients with mitral regurgitation in the general population. And they compared their survival with those of the general population according to census data and life tables. And what you can see from here as well, irrespective of the cause of mitral regurgitation, if you have it, it increases your mortality. The unadjusted hazard ratio was 1.57. Interestingly enough, if you look at these same patients and try to understand what impact their comorbidities have on their mortality, with also having MR, you can see that the things that affect their mortality, lung disease, if you have significant lung disease, your mortality is higher. But again, you see the same issue with age. So you start to see that your risk of dying when you have MR is increasing with age, irrespective of your comorbidities. Interestingly enough, the presence or absence of LV dysfunction didn't seem to have an impact on mortality, but mortality was definitely affected by the age of the patient. When we talk about secondary MR, you've probably also seen this. Obviously, functional MR patients who have decreased left ventricular dysfunction, but in principle, a normal mitral valve. There is a consequence of having mitral regurgitation, and the presence of severe MR in the presence of LV dysfunction does contribute significantly to mortality. Thus, now I'm going to French. Thus, as a result, we now know that possibly treating MR may have an impact on the mortality of these patients. We don't know that for sure. We have randomized trials ongoing, but definitely having it is probably not an innocent bystander, probably does affect your mortality. Why don't we operate on all these patients with mitral regurgitation? Well, oftentimes they're denied surgery for various reasons. Age, important one, congestive heart failure, diabetes, and significant comorbidities. And what you can see from the series from the Cleveland Clinic is that if you have functional MR, almost half the time you're going to be treated medically. If you have degenerative MR, about 20% of the time you're going to get surgery. But for the most part, patients who are decided for medical therapy, it's on the basis of their age and the fact that they have functional MR. What happens to you if you have functional MR and you're treated medically? So in this slide, you can see in blue your mortality from 1 to 5 years, and in the lighter blue, the chance that you're going to be hospitalized for heart failure. So if you get treated medically and you have MR, you have a 20% mortality at 1 year and a 40% risk of being hospitalized for heart failure. At 5 years, 90% of patients are hospitalized for heart failure, and 50% of patients are dead. So I'm going to go to a clinical case I think is interesting for particularly this audience. This was a 67-year-old male with a congenitally corrected transposition who had defibrillator for secondary prevention of ventricular tachycardia in 2000. He had coronary artery disease, had previous PCI, and had severe aortoiliac disease. He'd been referred back to the congenital clinic for progressive dyspnea, pulmonary edema. He had severe tricuspid regurgitation, so remember systemic RV, mild right ventricular systolic dysfunction. The heart team evaluated, so our congenital surgeons, congenital specialists. Patient was felt to be very high surgical risk. And so we're just trying to decide what is a potential option for this patient. So we'll get back to him later. What we're talking about today is the MitraClip device, which I'm sure you're all aware of. This is what the device looks like. Up close, this is the actual clip, cobalt chromium. You can see the grippers that trap the leaflets between the clip. And this has been approved since October 2013 in the United States and April 2014 in Canada for a high-risk degenerative mitral regurgitation indication. So we're going to talk about MR and MitraClip, and I'm quite a fan of reality TV, but my brand of reality TV is actually CNN. Particularly with Donald Trump, it's even more exciting. But I'll go back to one of my favorite quotes from Donald Rumsfeld, which is that there are known knowns, the things we know that we know, the known unknowns, the things we know we don't know, and then, of course, the unknown unknowns. So I don't know about the unknown unknowns, but I'm going to talk to you about what we know and what we know we don't know. So who are the ideal candidates for this therapy? What do we know about the use in degenerative or primary MR? Use in secondary or functional MR. We'll talk about some results on safety and durability, and then one of my interests, which is cost effectiveness. So in terms of anatomic criteria for MitraClip, I'm sure you've all seen this slide. This is the Everest criteria. So non-rheumatic MR originating from the central part of the valve and these exclusions as well as the mitral valve area. We don't really use any of these anymore. This was Everest 2 criteria. And now in 2017, these criteria are less used, and this device can be used for either degenerative or functional MR. And the feasibility of the procedure is really determined by the procedural team, what they feel they're able to do. The real exclusion here is still a mitral valve area less than 4 because of the risk of mitral stenosis. So again, the way to measure mitral valve area, short axis, transgastric, or with 3D now planimetry to get you a mitral valve area of 4 centimeters squared or greater. As you remember, in the Everest criteria really refer to central MR, and now there's several publications that show you can successfully treat non-central primary MR coming from either of the commissures, where you essentially just create a single orifice mitral valve, but this procedure is also very successful. So we're no longer limited to the central MR that we used to see in Everest 2. Going to Everest 2, what did we learn? I'm not going to review with you the entire trial, but I think there's a few important points we need to talk about. One, this was a trial of surgical candidates that were randomized to either surgery or device. At the end, there was no difference in mortality between the two groups. The main difference in the primary endpoint was surgery for significant residual MR, and that occurred primarily early, prior to hospital discharge or in the first 6 months. We did learn that MitraClip therapy was safe. The risk of major adverse events was around 15% compared to 48%, mostly driven by transfusions, but even if you exclude transfusions, there was a difference. If we look at the 5-year data that's available now, what do we know about durability? We can tell from this 5-year data. Beyond 6 months, where the majority of conversions to surgery occurred, there was no difference in the rate of freedom from surgery for mitral valve dysfunction, 77% with MitraClip versus 76% with surgery. No difference in survival as well at 5 years, and independent predictors of mortality were the presence of functional MR, COPD, older patients, diabetes, etc. In terms of symptoms, you see both technologies are essentially comparable at 5 years. Patients get the same effects on their symptoms with either percutaneous technology or surgery. The other interesting thing I think to note here is where we've progressed from Everest. So if you can see here is 77% procedural success in Everest 2. If you look at the more recent Sentinel data from 2016, we're now looking at procedural success of 95%. So we have increasing procedural success with increasing operator experience. So to go back to now secondary or functional MR and cost effectiveness. So secondary MR, a lot of the early data came from the high-risk registry of Everest, and this actually showed that when you treat these patients, these were not randomized patients who were in the registry, you could reduce the predicted mortality from 18% down to 4%. Probably more important for this group of patients was not the predicted or observed mortality, but rather the reduction in hospitalizations for heart failure. And you can see if you look at patients in the year prior to their intervention and the year post, the number of hospitalizations for heart failure was decreased almost in half. If we look at smaller studies that look at patients with severe LV dysfunction, we can see improvements in MR and T-proBNP, but most importantly, we can see that the therapy is actually safe in this high-risk population. This is just a table showing you all the different studies or all the different registry data available predominantly in functional MR. As you can see, the majority of patients treated worldwide, particularly in Europe, are functional MR. You see high procedural success, and you can see we've got hundreds of patients treated. Unfortunately, not in a randomized controlled trial, but these are real-world patients, and we have data available on these patients. I'm going to review for you just Access EU, which was published in 2013, but what I want to draw your attention to is MR severity, durable to 1 year in these patients with functional MR, procedural success in 80% of patients at 1 year. And these were a high-risk group of patients, and they showed again in high-risk real-world patients that the procedure was safe and the mortality was low. We did our own analysis of patients that we actually treated at the Montreal Heart Institute with MitraClip to try to understand if there might be a sweet spot where the benefit is no longer visible in this patient population or patients who might get more benefit. And in fact, what we found is the lower the EF when we did the procedure, despite the fact of being able to reduce the MR, we couldn't change the mortality, which is not surprising given the population of patients that we're looking at. So this is what we found. If your EF is less than 27%, even in the case of reduction of MR, you still have high mortality. And that's basically from your underlying comorbidities, particularly your LV dysfunction. This similar finding was seen in the Access EU registry when they did a similar analysis just published last year. Again, the lower the EF when you start, even though you can reduce the MR, it may not have the impact you think on long-term outcomes. We also wanted to try to evaluate cost effectiveness. As you know, with these transcatheter therapies, they're more and more expensive. Is there a limit that we can't spend beyond, or how much value do we get for our money with this technology? This was an analysis we did based on the high-risk registry data. We also did another analysis looking at heart failure patients, and essentially what we found is that treatment with MitraClip is cost-effective. We had an ICER of around $36,000, so just to put that into perspective for you, it's somewhere between Crestor in the Jupiter study and Herceptin for breast cancer. So it is a cost-effective therapy. Where we're going to find the money remains to be seen, but it is something that we can use for patients with heart failure. So to go back to the things we don't know what the impact of this therapy is on long-term outcomes, particularly in heart failure patients. And this is what we're hoping the randomized COAP trial will tell us, randomizing patients to medical therapy or MitraClip and trying to evaluate heart failure rehospitalizations and mortality. Hopefully enrollment will be finished in the next 3 to 4 months, and we'll have data a year from now. As well, what is the utility of this device in intermediate risk patients? So there is a study ongoing in Europe, and hopefully that will provide some insights. And then again, the looming question with transcatheter valve replacement, what is the role for a transcatheter mitral repair? So all things we certainly don't know at the time. So if we go back to our case, this patient was felt to be too high surgical risk and was subsequently referred to the MitraClip clinic for MitraClip. We took him to the cath lab. As mentioned in the echo for these types of patients is actually significantly difficult to image, and so we did this entire case from the transgastric view just to try to see the valve leaflets. But you can see the regurgitation is definitely central between the septal and posterior leaflet. Here you can see the regurgitation. And this is the 3D imaging. So the 3D imaging was also very helpful in order to position our clip in the appropriate segment. So here you can see the procedure, so much the same as a standard MitraClip procedure, transeptal, etc. Just the clipping becomes more difficult because you obviously have 3 leaflets. And sometimes seeing the leaflets and knowing which ones you're clipping together can be a little bit challenging. So we managed to put 1 clip on this patient and actually successfully reduce the MR. So here you can see somewhat of a double orifice. So we reduced the MR to a residual of mild to moderate, about 2-on-4. This was 3 years ago now, actually. This is the device delivery. So we reduced the MR to 2+. There was no tricuspid stenosis. The mean gradient was 2. The V wave went from 47 to 19. He was discharged at day 4. He hasn't been readmitted for heart failure since. It's been 3 years now. And we published this actually in CCI with just some nice pictures and some instructions and sort of tips on how to do this. So just to finish for you, mitral regurgitation is an important clinical problem. We're still struggling on the best way to deal with it, but we do know that the MitraClip can be used for both degenerative and functional MR. It is safe and effective with high procedural success, and in particular in the Canadian public healthcare system, the data is suggesting to us that it certainly is cost effective in high-risk patients and those with heart failure. So thank you.
So we're pretty good on time. Any questions for Anita about MitraClip? Let me ask you a question. What's the sweet spot for a big hospital in Canada for volume? Like what's like a reasonable volume to be doing where your skills are reasonable, and how many cases are you guys doing a year? Where do you see it going? Is your volume steady or is it growing every year?
So just a couple of things. I think one of the MitraClip is again a perfect example of where the team is very important. So it's not just the interventionalists, your imagers are very important. And so we have a philosophy since we started in 2010 that we have 2 imagers that are with us all the time. We have a volume of between 35 to 40 cases per year. And so our imagers are very good because there's just 2 of them dedicated to the procedure. And the same, we have 2 interventional cardiologists that are doing this. With time, you find you become a lot more efficient. You know, the team works together better. I think, personally, I would say that a minimum of probably 25 cases per year, because if you have 2 imagers and 2 interventional cardiologists, you're only talking 10 to 12 cases per year, which is not a huge volume. The learning curve is relatively steep. I think if you'll talk to some of the newer operators, in the beginning it seems quite challenging, and as you get up over, 30 to 40 cases, it becomes a little bit simpler. We're up to almost 200 cases, and our procedure times are down very quick. We can do a case in 40 to 50 minutes. So I think, and again, that's great imaging, and then, the whole team knowing what they have to do. I think if you're a center that's doing less than 25 cases, it's probably going to be challenging to have as good outcomes as you would like. We still get a lot of referrals, a lot coming now from out of province as well. So we're covering pretty much the east coast of Canada. Newfoundland, New Brunswick, Nova Scotia are coming to us. So I only see it growing. My wait list is just getting longer and longer. The limitation that we're having is getting reimbursement from the government of Quebec and then convincing the administration that, we need to keep increasing our volumes.
Because traditionally that's never been a problem, getting reimbursement from the provincial government, right?
Yeah. But Anita, if you
Try living in Quebec.
the cost effectiveness data. So does you've used that obviously probably to push the government for more funding. Has that helped at all?
They understand that, but at the same time, dead patients don't cost anything. And you try to build the argument that we save hospitalizations and that saves money. But at the end of the day, if they have, TAVI, MitraClip, CRT, defibrillators, they
see us as piranhas type of thing.
kind of. They just see us, we have a new gadget, we just want to put it in. So it's an uphill battle, but we're getting there slowly.